Hello my friends and colleagues, it's Mike coming at you from Seattle, and we are back this week talking about whiplash. I just finished my week of treating patients, and guess what? This week, like many weeks in my practice, I saw folks suffering from whiplash-associated disorder. It is so incredibly common for folks to have a history of injury in the neck and head associated with whiplash that it is just crucial for us all to continually refine our learning in this area. And that's a big reason why I'm prepping this upcoming class and why I hope you can join me. Now, last week we talked about whiplash from a biopsychosocial perspective, from an ecological perspective. We talked about the contextualized reasons why whiplash follows a course of healing which is not always straight, and why it often has feedback loops that perpetuate someone's inflammatory response, perpetuate their suffering. This week I'd like to make the case that there are specific tissues that get injured in whiplash and that are amenable to your treatment. Often not talked about when it comes to whiplash injury are the neural tissues themselves, the fibrous covering of the central nervous system, that is the dura mater, and its extensions in the form of nerve roots and nerves. And we must think of this system as a continuous cloth. So we like to say in bodywork, physical medicine, that it's all connected, but the truth is that some things are more connected than other things. And one thing that's very connected is the fabric of the dura mater and its connections outward into nerve roots. Now I want you to review for a moment the predicament that the dura mater has. It's a pressurized water balloon enclosing the central nervous system, this incredibly important structure. It's pressurized to about 2 to 3 kilopascals, which is like if you push into a bike inner tube. It's in that range of pressure. It's a tough and inelastic tissue which you would have trouble stretching or breaking with your hands. So it is strung from the head down to the tail. It exists within the spinal canal, and the dura needs to be able to redistribute its fabric passively in order to normalize fluid pressure inside the central nervous system and in order for nerves to function optimally. So the problem comes when the tension or the pressure on this dural water balloon is met with excessive force. Now think about how you would test for mechanical stress in the dural tube. Something like a slump test. You would bring the head into flexion and you'd bring the tail toward the head. In a way, you'd sort of bend yourself into a forward slump, and then you would selectively stress the sciatic nerves by bringing the legs up into flexion as well. Think now about the position someone finds themselves in the moments before a classic car accident, car collision. They are slumped in a car seat. Their legs are out in front of them, and not only that, they are anticipating impact, perhaps. So they are bracing, depressing the shoulder blades, and thus tensioning the upper brachial plexus. They are probably pressing their feet, or at least one foot, into a brake pedal. And they are dumping stress cytokines, stress chemicals into their bloodstream, hypervigilant in that moment. This is the predicament that the dural system finds itself in the moment before a typical whiplash injury. Tensioned, slack mostly taken out, and it's a situation where the dura and nerve roots are at some risk for injury. The degree of injury that happens on a spectrum, sometimes not very much injury to the dural system. Hence, we are fine if we just want to focus on segmental mobility in the neck or scalene muscles or whatever else, but sometimes it forms a crucial piece of the injury story in whiplash, and we would do well to keep that on our radar as we do our assessment. In particular, the architecture of the dura in the neck is really interesting. Surrounding the dural balloon in the neck, there is a peridural membrane. There's a surrounding architecture around this dural balloon that links it to the vertebra, especially at the transverse foramen where the nerve root exits. There's a little bit of a fibrous connection between the nerve root and the cervical vertebra, which means that when you reach your hand out and tension a nerve in the lower half of the neck, there is some lateral glide to a vertebra drawn along by that neural tension. Likewise, when you tension the nerves bilaterally, there is some relationship between the vertebral motion and the dural motion there, and potential for injury. Now, I'm linking you to several studies showing that mechanical trauma to the dural system is a thing that happens in whiplash injury, and it's also a thing we can assess for. We can assess for it systemically by taking the slack out of the dural tissues and having a person move their head in context-specific ways, that is to say, ways which relate to their meaningful activities. We can also utilize this dural system to improve our treatment. We can take the slack out of nerves while we work on vertebral segments or on muscular attachments, and thereby potentially relieve ongoing stressors onto an already sensitized dural system. Now, when you think about a single vertebral segment, I want you to imagine that that bony segment is floating around a dural balloon, and that on each side you've got a pair of nerve roots exiting and sending projections ventrally and dorsally. Now imagine that one side of that system is under more mechanical tension than the other. The dural balloon will migrate to that side of the spinal canal, and that nerve root will be under somewhat more mechanical stress with its local bony foramen. Shacklock and others have shown that if you tension the opposite side nerve root, you actually relieve some stress on the initially stressed root. Why? Because tensioning the opposite side gently pulls down the dural tube a little bit, and thus causes a kind of shouldering down of both nerve roots and less sort of shear stress right where the nerve root exits the dural balloon. So keep that in mind, that if you've got a stressed nerve root on one side, you can actually relieve that stress a little bit by tensioning the opposite side, and thus somewhat normalizing the pressure on that root. Likewise, you can play with increases or decreases to dural tension on the bottom end of the body by having someone reposition their legs or their pelvis. And likewise, you may be able to modulate the level of stress happening at nerve roots if indeed you suspect that irritation or injury to cervical nerves is part of the story in a whiplash patient. Lastly, I just want to open your palpatory lens to the possibility of feeling these nerves, especially when they're irritated and inflamed. If you approach the cervical spine from a diagonal aspect, that is to say, lateral to the spinous processes and the midline muscles, but on either side of the levator scapula. So either sort of on the posterior or the lateral aspect of levator scapula, you can approach the lamina, the deep paraspinals, and the associated exiting dorsal ramus nerves. At that level of denser connective tissue, if you explore at that depth, you will feel little gummy structures, little stitches in the cloth that prevent the sliding of your hand as easily there. Those places are likely sites of perforation where dorsal ramus nerves are coming through the more superficial muscle and anchoring it there. They may reproduce familiar symptoms when you palpate those dorsal rami nerves, and especially if they're inflamed, they will be swollen. They will feel like pressurized nodules in the middle layers of the cervical spine. And they will not have the sort of linear fibrous quality that tense muscle fascicle has. They will feel like a warm, swollen nodule that is sort of embedded amongst the muscles of the posterior neck. That's likely to be a dorsal ramus nerve that is irritated and inflamed, and it doesn't respond the same way as muscle tissue does to your well-meaning palpation. Likewise, if your primary lens as a manual therapist is the segmental mobility and stability of the cervical spine, perhaps the health of the facet joint as a potential generator of cervical spinal pain, keep that nerve picture in mind. Keep that dorsal ramus in mind, because it is the innervation site of that facet joint from the dorsal ramus medial branch where you are most likely to find discomfort that reproduces familiar pain. And so it may well be that what we used to think of as facet joint treatment friction is most likely actually affecting the medial branch dorsal ramus nerve. And this dovetails well with some of the skeptical debate we've had about the ability of manual therapists to affect change in collagen structures. How likely is it that we are able to access a specific layer of facet joint capsule and then splay those fibers under our fingertips versus contacting a layer where there's an irritated dorsal ramus nerve and then mobilizing the sliding interfaces there enough that the dorsal ramus can re-regulate its inflammatory state, its state of mechanosensitivity. That may indeed be the local tissue change that we have found so valuable when we do treatment work at a musculo-tendinous junction, at a facet joint in the neck. That local frictional work that seems sometimes so valuable, perhaps it is a site of innervation being re-regulated as opposed to a collagen structure being reorganized by your hand. I'll leave you with that today. I'll try to post some more videos later in the week, but if you have a chance, check out the linked research articles, and I hope to see you in class on Saturday. You can join me live or you can watch the class anytime. Just be sure to be on the roster before class. Thanks for your time. Have a great day, and may we all help some folks with whiplash this week.